To do a proper assessment of a patient, you have to start with a good history, which helps you direct the rest of the assessment of the patient depending on what you find. With a skilled history, you'll know where to go. If you want to go to the cardiovascular system, the same thing applies. You need to do a skilled examination to know how to go any further in the assessment for a given patient. It's going to be a very long time before we have a machine that you could just put a patient into and get all your answers. And it's going to be a long time before that will happen in countries that cannot afford such a machine, which has not yet been developed. So let's move forward on how to do a proper physical examination. You should understand that each maneuver that you use to do a physical examination has a certain amount of value, sometimes not at all in some patients, but maybe of high value in other patients. So you need to do the whole exam because you don't know what you're going to find. It doesn't cost much money, it doesn't take much time, and it helps you direct you further towards the assessment of a patient and subsequently how to manage a patient. So I'm going to take you through each of the steps without talking a whole bunch about different diseases, but I may give you a few examples of how you can tell the absence or presence of severe disease. You can actually assess the severity or how mild it is depending on what you find, and sometimes much better than a lot of the equipment that's available to take you through more sophisticated assessments. So first of all, we're going to start with the radial pulse. Stop. Starting with the radial pulse, just use your two fingers and have the patient relax. They don't have to be lying down, but that's often where you start. Now you should understand that the radial pulse will be normal in many people without disease, with all people without disease, and in many people with all forms of disease. But when it's abnormal, it can be an incredible cue to look for what you're going to see later on, and also sometimes even the only clue that you have a severe problem that may otherwise be missed by the full physical exam and also by the occasional assessment with, say, an echocardiogram. This is a rare thing, but it can actually happen. A good example of something that you can pick up right away in many patients with severe disease is aortic stenosis. There's a characteristic pulse. Many teachers will tell you not to bother. I'm telling you, they don't know what they're talking about. You do the radial pulse to pick up valve diseases as well as other diseases, but also in particular you do that for arrhythmias. You can get a wonderful clue as to what the arrhythmia is that you're dealing with, and that helps you direct the rest of your examination. Okay? The brachial pulse is easily felt if you get right beside the biceps tendon in most people. It gives you the same kind of information that you get from the other pulses. It's just often it's easier to feel it, and sometimes the information is a little bit different, and that can be helpful too. So don't ignore the brachial pulse. The next important pulse is the carotid pulse. The carotid pulse should be felt with both the thumb and the finger. The thumb is a good way to feel the changes in the carotid pulse when it's abnormal, particularly if there's a shudder, which is basically a murmur that's transmitted to the carotid pulse, and sometimes little hesitations or extra bumps in the pulse. You don't worry about your thumb feeling an extra pulse like you do when you're looking at the peripheral pulses. You'll always be able to tell the difference. So just when you examine the patient, if you're looking at the right carotid and you're right-handed, just go in beside the larynx, go into what is a bit of a depression down there, and it's not hard to feel the pulse. Feel it with different degrees of pressure because some things are better felt than others with light or stronger pressure. Many of the abnormalities that are felt in the carotid pulse also help you decide on how severe the problem is. Now, the difference between the radial pulse and the carotid pulse is interesting and often not recognized, and that is, as you go further away from the heart, the pulse pressure becomes greater. So that if you're looking for something that has a rapid rising pulse, it's easier for you to detect it when you're further away from the heart, because it's going to rise even more quickly. If you're looking for something that's more subtle in terms of the rising part of the pulse, the one at the carotid pulse, which is closer to the heart, doesn't have as high a pulse pressure, and it's not as difficult to pick it up. Examination of the jugular venous pressure is a difficult skill, but you should understand that if you can examine the jugular venous pressure, you know an awful lot about the filling pressure in the right side of the heart, and it often gives you a good indication as to what the filling pressure is in the left side of the heart. And even more important, if it goes up, if the jugular venous pressure goes up, then indicating the increase in right-sided pressure, it always goes up as well on the left side, but they may not be equal. The point is, if it's up on the right, it also goes up on the left. If it's coming down on the right, then it's coming down on the left. In the treatment of heart failure and in the detection of heart failure, the jugular venous pressure is one of the most important things that you can assess, but it's remarkable that so few people even try. And I think the best explanation for that is that it's difficult to do it well. When you're examining the jugular venous pressure, the position of the patient is critical. If, for example, the patient has a normal jugular venous pressure, there's a reasonable chance that you will not be able to see it when the patient is standing or sitting because they're so far above the heart. But as you lower the patient's position, the jugular venous pressure will become more clearly seen. So I'm not too persuasive on trying to work out the different pulse wave patterns, because that takes a high level of skill, and I wouldn't be giving this kind of a lecture to an audience who needs to know that level of skill. I would be giving a much more detailed lecture. So for the moment, I think we will just focus on just what the pressure is. So if a patient is sitting and the jugular venous pressure cannot be seen, then you would progressively lower the patient until you can see it comfortably, and that's the position where you will decide what the pressure is. And what you do is you measure the level of the pressure. For example, it might be where my finger is, above where you think the right atrium will be, which is about the mid-axillary line. So you judge that over here. Okay? Normally, in a person like our medical student here, it would be seen in approximately this position. Many people will teach you to turn the patient well over to the side, like that, so you can see it better. And I think that's the wrong thing to do, because when you do that, the skin becomes very tight, and the pressure is more difficult the pressure in the vein is more difficult to assess. So what I normally do is I have the patient's head in the midline, a little bit to the left, or just a little bit to the right, so the skin is just a little bit loose, but not very loose. And then try to get a good lighting. A pen light is not as good ambient light, just a room light or sunlight. And look very carefully in here. And while you're doing that, I'm doing it the wrong way to do it. I'm going to feel the opposite carotid for timing purposes. If you see a pulsation here that's different than the pulse on the other side, you're looking at the jugular venous pressure, the jugular venous pulse. If you can't see it, then you lower the patient little bit until you can see it better. And again, check the other side to get your timing in. Because remember, the 2 or 3 pulsations that you'll be able to see will be different than the carotid pulse. Then you would measure that above here if you wish to, but more commonly above the sternal angle. So you might say that it's 2 centimeters above the sternal angle. And the sternal angle is 5 to 6 centimeters above the right atrium. So it's more difficult to measure it above here. So it's easier to say above the sternal angle and add 4 to 6 centimeters to get a right atrial pressure. So in his case, I was able to see it fairly easily, maybe 1 or 2 centimeters above the sternal angle. So he probably has a right atrial pressure of approximately 5 centimeters, and that's normal. Let me emphasize that so much of what goes on with heart failure, both the fact that you have to detect heart failure, and the management of heart failure is very dependent upon changes in the pressure in the heart. And the only really good reflection that you have of that is the jugular venous pressure. You must learn how to do this in order to decide whether someone's in heart failure, whether or not you're making the heart failure worse, too dry, for example, when you can't see the jugular veins anymore, or too wet when the jugular veins keep going up as you give them whatever treatment you're giving them, including if you do volume infusion, even to a normal person, if your jugular venous pressure is rising above normal, then maybe you're giving too much fluid. There's no other easy way to tell at the bedside. So you have to learn that special skill if you want to be a good bedside clinician. Next, I'm going to demonstrate how you palpate the precordium. You should understand that although it will be normal in many patients, even patients who have abnormal cardiac disease, it sometimes gives you an excellent clue as to what may actually be wrong, and tells you and gives you a good helps you get the direction of assessment while we're telling. Should you do this, that, or the other thing, an echo, an ECG, or whatever else. So the first thing you do is you feel with your fingers on the right side of the sternal notch, subclavicular region, and sometimes you'll feel a pulsation there. Usually you don't. If you feel a pulsation, you want to see what it might be. It could be the aorta. You can also feel sometimes very loud murmurs that are called thrills. So you should feel very carefully there. It doesn't take long. On the left side, you usually will not feel the pulmonary artery, but in a skinny person, you may feel the pulmonary artery, just barely feel it, and that could be normal. When the pulmonary artery becomes big, or under high pressure or high flow, then you may feel it here, and that's a good clue that you have something wrong in the pulmonary vascular system. You should also feel the clavicles to see if there are any pulsations. If there's a pulsation in the clavicle, that often means that the artery that's underneath it is abnormal. For example, it could be an aneurysm of the aorta. Now, when you should feel along the left sternal border with the palm of your hand, and just go down a little bit at a time to see if you feel any pulsations, or if you feel any heart sounds or any thrills. Normally, except in skinny people, you will not feel much of a pulsation. So you should know that the right ventricle sits here in front. The right ventricle really is an anterior ventricle. And if it's working too hard, increased flow or increased pressure, you can feel a bump there, and that's helpful in trying to decide whether somebody's right-sided pressures are too high, for example, pulmonary hypertension. And then you should also feel with your fingers towards the apex, which is the left side in a normal person underneath the nipple. You want to locate the pulsation, the furthest location of the pulsation, to see if the heart size may be increased. If it's outside the mid-clavicular line, the heart may be increased in size. But the additional information you get is whether the left ventricle is working too hard. In other words, if the pulsation is short, the left ventricle may not be working too hard. But if the pulsation is prolonged and increased in size, then the left ventricle, for whatever reason, is working too hard, and you've now learned something about the physiology of that heart. Even if you don't know what's wrong with it, you know the left ventricle has a problem. The next thing you should do with precordial palpation is to turn the patient on the left side and reach over with your arm and try to feel the apical impulse again. The location of the apical impulse is not so clearly anymore an indication of the size of the heart, but because it's closer to the chest wall, you can get a sense of whether it's working too hard and if there are any extra pulsations. For example, if the atrium feels like it's got to work too hard to force blood into the left ventricle, then you can often feel what basically is the atrial contribution to left ventricular filling. And that means that the left ventricle, for some reason, is stiffer than it should be, and that's an indicator of disease in most people, not always. Especially in older people, it may not be abnormal. But in a young person, you should not get that extra bump from the left atrium. You can also get a left ventricle that's sick and maybe big and floppy, so that when it fills in the early diastole, you can actually feel that pulsation too, and that tells you that you have a sick heart in a person who's not young. As people get older, the filling pressure wave is not felt except in very young people and only occasionally. So you put your arm over the side, you position it, and you feel for the apical impulse. And when you locate it, what you do is you feel with your fingers to try to characterize it for size and also how long it lasts and whether or not there are extra bumps. So now we've done a part of the physical examination that is so often not even tried by physicians. And that really is kind of sad because it doesn't take long and you can get a lot of information about somebody who's got a problem. And if you can't find anything to this point in the examination, the likelihood of severe disease now is only small, and there's a good likelihood that there's no important disease, at least in severity, in this particular patient. Now, this is not absolute, but at least for the price of the time and effort that you've made, you've learned a lot about the patient. The next thing that you want to do, of course, is auscultate. Auscultation is very difficult and people who are difficult to listen to, but before you even start thinking about the patient, you should think about the actual stethoscope. If you talk to somebody who understands sound systems, like stereo systems, they'll tell you that the sound is going to be as good as the worst part of your system. And unless you're an unusual medical student, the brain is not the worst part of your system. The hearing is not the worst part of your system. It's the stethoscope that's the worst part of your system. There generally are two heads to a stethoscope. There's the flat part and there's the bell. You want a stethoscope that is reasonably heavy and the diaphragm should be fairly firm, and it's very good for picking up high frequency murmurs and sounds, for middle frequency for murmurs and sounds, but it's not particularly good for low pitched sounds like a diastolic rumble of mitral stenosis or an S3 or an S4. When you apply this to the chest, you apply it firmly so that the high-pitched sounds actually come through. The bell should be deep, not shallow like this one, and it should be applied softly to the very specific areas to look for low-pitched sounds, S3, S4, and diastolic rumbles. If you have one with a shallow bell like this one, Or if you apply it too firmly to the skin becomes like a diaphragm, and you may filter out the low-pitched sounds, for which this is very useful. There should be good ear connections, and these soft ones that they've brought along in the last few decades are far better than the very hard ones that we used to have, because they will fit your ears very well. 2 tubes are better than 1, and they shouldn't be more than 18 inches long. Unfortunately, stethoscopes are expensive, but this one should be considered good for blood pressures and bowel sounds, not for cardiac examination. So I will use this stethoscope to show you where you would put your diaphragm or your bell to examine. Normally you would start on the right sternal border, the left sternal border, and then you don't go down because someone says this is this area and that's area. You go down in small increments along the left sternal border all the way out towards the apex with the diaphragm. Now, the bell will not often find you any murmurs at all. Sorry, it won't find you any extra sounds or low-pitched murmurs that you haven't already heard with your diaphragm until you start moving down the lower right sternal border, where you might get right ventricular filling sounds, and S3 or S4, but that's not easy to get. And then at the apex, you should listen with it lightly applied to the skin right at the apex. But as I said earlier, when you bring the left ventricle closer to the chest wall, in the left lateral position, go ahead, turn it inside. Feel with your fingers for the apex and apply the bell lightly to it, and only move around a few centimeters in that area. And that will pick up murmurs of mitral stenosis in particular, or other rumbles, and S3s and S4s. Now, you may want to be a family doctor, you may want to be or another non-generalist, but you should understand that if you pick up these findings, you can help prevent a tragedy. And I've seen this happen because the physical exam wasn't done well enough to begin with. Having examined in this position, you also want to examine in the sitting position. In the sitting position, there's the 2 main things that you're looking for. One is the high-pitched murmur of aortic regurgitation, which can be heard here at the second right interspace, but most often is heard better along here. And one of the problems with listening for that kind of a murmur is that if the patient continues to breathe, a very soft, high-pitched murmur can be easily missed. So what we often do is we have the patient bend forward, hold your breath, and listen like this along here for the murmur of aortic regurgitation. Okay? The other thing that it's important for is the second heart sound. The second heart sound varies with respiration. It's generally heard as one sound in expiration, and as the person breathes in, the second heart sound normally splits, especially in young people, like this. Expiration, inspiration, expiration. Abnormalities in the second heart sound can be very important, and they should be listened to in the sitting position on a regular basis, not only in the lying position, where the second heart sound can be quite variable when it opens and closes, and you might really get fooled. But the physiology of sitting is that there's increased inflow into the heart during inspiration and decrease during expiration, and that is predictable, and therefore the second heart sound should be more predictable. You can also find that the second heart sound is loud. For example, in pulmonary hypertension, the pulmonary component will be loud, and if you have pulmonary hypertension, you got a big problem, and this is the first clue maybe that you'll find that this person has a real bad problem. The other thing, of course, is that you may be able to feel the right ventricle pulsating here, and that will give you an indication that maybe the right ventricle is working too hard. Once you've done this physical examination, you've done more than almost everybody in your country. However, you're better at it than almost everybody in your country, because this is very important to do this. Otherwise, important things can get missed. And when you go through your medical school and your early training in the bedside, and you find somebody with a newly diagnosed AS, atrial septal defect, it's because nobody examined that patient properly. Or you find someone at the age of 20 or 25 with severe mitral stenosis, it's because nobody examined that patient properly before. And you should be able to do a better job than that the first time you see a patient. Now, I don't expect you to be very skillful at this in the early years of medical school, but as you go through practice, you get better and better at this, and if you get lazy and stop doing it, a lot of patients will not do well because you're lazy, and that's not why you went to medical school. Next time you hear me giving this sort of thing, you're going to be a cardiology trainee, and we'll spend approximately 2 hours doing what I did today in half an hour. Because we'll talk about all those diseases and all those subtle things that are so important in directing the assessment and the management of patients. Good luck.